All right, good evening, everyone. My name is Fedrick Ingram, the Secretary Treasurer of the AFT, and I'm stepping in for Randy tonight. I am from Florida, born and raised, and mostly proud of that. But since the last election, I say we are all from Florida now. As many of you know, these retrograde policies that we see being implemented across the country usually get their start in my home state. From book bans, attacks on the LGBTQA community, and now anti-vax policies and conspiracy theory policies are having their moment as Florida's Surgeon General pushes a ban on vaccines for school children, while our National Secretary of Health and Human Services is pushing the debunked link between Tylenol and autism. These backwards policies are just ridiculous. And they're not just ridiculous, they're dangerous. Putting the lives of our children back in the crosshairs of diseases we have already defeated, like polio and measles. The established medical community is not just outraged, but scared at the implications of our government, both national and local, resorting to such fallacies. They know the health of our democracy cannot be sustained on myths and lies. That's why tonight's conversation is so important. There's a lot of misinformation out there about childhood vaccines and health. Families and educators are doing their best to make sense of it all. But the noise can drown out the facts. And so we're lucky tonight to have two experts who can help us cut through the noise. Dr. Vin Gupta, a trusted voice on public health, and Dr. Demetre Daskalakis, who led the CDC's National Center for Immunization and Respiratory Diseases. Thank you all for being here. They've been on the front lines of major health crises for a long time, and they'll help us separate facts from fiction. And before we close, we'll save the last 10 minutes for your questions on other health issues too, like Tylenol and pregnancy, and whatever else is making the news today, which is a lot these days. So let's get started on not only restoring our health, but our faith in education and the expertise of those who want to help versus those who want to grift. I'm going to turn it over to Dr. Vin Gupta.
Thanks, Fedrick. And Dr. Daskalakis I'll be bringing him in just a moment, but just to level set with all of you, and I know we have a national audience here, I really recognize that this is not, it's never easy to find a good time that matches or suits the East Coast and the West Coast and the time zones in between, especially on a weekday. So thank you to all of you. The American Federation of Teachers, AFT, is, we started doing this back in March when measles was really taking root in West Texas. And I remember Randy and I started having conversations again and reminded us of the pandemic. How do we bring trusted health information on issues that matter to all of you and your families in a way that's accessible, free, digital. And so we started these national town halls and started with measles back in March. We had Dr. Jerome Adams talk to us about ADHD and youth mental health in April. For those of you who have stuck with us for every single town hall, every single month, you'll remember that we did perimenopause awareness in May with two leading obstetricians and Randy stewarding that conversation. In June, we were joined by Dr. Mandy Cohen talking about wellness and longevity and just how can we focus on disease prevention. In July, we talked with Dr. Peter Hotez and the Autism Society on autism, facts and fiction. And I think, we know that this has been in the news a lot, especially in the last few weeks, but it's something that is relevant, is something that we need to be talking about, but talking about in an informed and trusted way. And I really thought that was the intent of that, and I thought that struck the right tones. In August, we were pleased to be joined by Dave Chokshi, former New York City Department of Health Commissioner, to talk about back to school. And now we have the distinct honor of having Dr. Demetre Daskalakis, who until very recently headed the National Center for Respiratory Diseases and Immunizations at the U.S. Centers for Disease Control. I'll let Dr. Daskalakis give himself or allow him to tell about his bio in just a moment when I bring him in. But the reason we're bringing Demetre in, I'm going to just do away with honorifics and just use first names here. The reason we're bringing in Demetre is he is an unparalleled healthcare leader. He has dedicated his life to public service, and he's an amazing health communicator. He really just helps break through the noise and cuts to the chase in a very clear way, and I think in a really trusted way. And I've really admired watching him and his career all these many years. We're going to focus, just to give you a sense, for the next 25 to 30 minutes on all things in the news. We're going to be focusing a lot on vaccination guidance. What are the changes? How is it going to impact you and your families? We're going to talk about the changes to the childhood vaccine schedule, at least those that we know have already been adopted. Why were they adopted, and what can you do to navigate a changing landscape? And then we are going to save some time, as Fedrick just pointed out, to talk about very newsy items that I think are causing a lot of confusion, like Tylenol and what it means were you to use it for, say, if you have a young child. Is it appropriate to use for your young child if they might have a fever? If you're pregnant, what should you do when it comes to needing, say, Tylenol for pain relief or to treat a fever? We are going to help you cut through the noise and make sure you have access to trusted information. So that's the point of this. We're creating these national town halls, or continuing them, because there aren't a lot of other recourses out there, and these are free. They're going to be syndicated. We'll clip up some of the best parts of it and share them on Instagram, on TikTok, on all social feeds, and make sure we have those assets readily available to you. And so, with all of that said, I'm going to bring in Dr. Daskalakis and Demetre. Thanks for being here.
Thank you, Vin. I'm using my phone, just making sure that you can hear me.
Yeah, perfectly.
Okay, good.
Demetre, just, I think a lot of folks are already familiar with you and your leadership. And like me, just thank you again for everything that you've done. And I know there's broad admiration for everything you've done. Tell us about just a little bit about yourself, if you don't mind. How did you end up at the CDC?
Sure. Well, first of all, it's really great to be here. I'm so glad to join the illustrious crew that has been able to be on this webinar. And so I think I'm an infectious disease doctor. That's where it all starts for me. And I really focused a lot of my early career on doing work in the HIV space, both clinically and then ultimately at the Department of Health in New York City, where I started off as the assistant commissioner for the Bureau of HIV Prevention. And soon thereafter, after having made some pretty significant changes in how HIV is run in New York City, I became the head of disease control, which meant like the boss over all of infectious diseases for the New York City Department of Health. And while I was there, I was involved in a couple of pretty important emergency responses, measles, and the COVID-19 response. So I was the incident commander, is what they called them, which is the sort of lead for the Department of Health for those two very big responses. Ultimately, I got to CDC because I wanted to lead the Division of HIV Prevention, was there for a couple of months, and then got pulled into COVID again, and worked in that space right around the first booster after in 2021. Did that work for a while, went back to HIV, and then Mpox happened and moved to the White House, where I helped coordinate that very successful response, and then ultimately landed back at CDC. And I think you already covered it. I was the director of the National Center for Immunization and Respiratory Diseases, and that's the part of CDC that focuses on many of the vaccine preventable diseases that we think about.
And also, sorry, a little bit of sound chaos. So also where the Vaccines for Children program lives, which is the program that's responsible for providing vaccines for about 51% or 50, actually now it's 54% of American children. So I was there until recently. I think a lot of changes were happening at CDC, a lot of things that made me very worried about science leading as opposed to what I was seeing, which was ideology. And so I resigned about a month ago.
Dimitri, well, thank you for that. And again, thank you just for an incredible career. We have you here, and again, for those that are live, thank you for joining us live. We're also going to be syndicating this information, so we're going to be reaching the 2 million plus membership of AFT and the general public. We post everything on publicly accessible websites. I wanted to get can you give us a sense, in the last 2 weeks, we've heard a lot about this ACIP committee. One, and people can see what it stands for, just Advisory Committee on Immunization Practices. Why are they revisiting things that, based on the science at least, it suggests that we shouldn't be revisiting, MMR, MMRV, all these sort of different acronyms of vaccine combinations. But can you give us a sense of what's happening and why it's happening?
Sure, and I'm going to probably start with just giving you a little bit of what ACIP is supposed to do. So its name kind of says it all. It's the Advisory Committee on Immunization Practices. The next question is, who is it advising? And the answer is it's supposed to be advising the director of CDC. So they give advice to the director, and then the director decides on vaccine policy, like who should be getting one vaccine or another. The FDA, the Food and Drug Administration, they do all the approvals. So they say this vaccine is approved to use. Then it goes to the ACIP, and they're the ones who make recommendations about who should get it. And so, until recently, it was really governed by a lot of really good scientific process. So there was a question, a new vaccine, something that came up, and then the ACIP would review all of the data over, frankly, many months. And then go through a process looking at all of the considerations, all of the bits and pieces that go into a decision.
We were told.
So recently, that changed with Robert F. Kennedy Jr.'s. Oh, am I back?
Can you hear me? We can hear you. We can hear you.
Okay. When Robert F. Kennedy Jr. started as secretary, he fired the 17 scientists that had been on the advisory committee and replaced them with people who were very ideologically aligned, who were, frankly, it's hard to say vaccine skeptics, because I think we all are vaccine skeptics. It's good to be skeptical, but who were actually pretty anti-vaccine in terms of what they did. So as opposed to sort of having a problem that is then discussed, what instead happened was an agenda was created and a couple of items made it on there where there wasn't apparently any good reason to discuss it. So, for instance, the MMRV, which you talked about, that's measles, mumps, rubella, chickenpox combination vaccine, which very few doctors had been using, but there was a movement to try to remove it from the schedule, not because of anything new, but because of the desire to remove it, and also a discussion around the birth dose of hepatitis B, which is a vaccine that's been very important in preventing hepatitis B in newborns, and that prevents liver cancer, liver scarring, and liver transplants. So, it's been a little strange because it's not working the way it normally works.
And last Friday, many people may have seen some of us try to immediately respond and provide some clarity to this, but the president seems to be a piggyback on some of these changes. And you've mentioned hepatitis B. This is a vaccine to protect against the hepatitis B virus causing chronic infection and liver problems. The president put out there, and just to get into the substance of it, that we should be moving away from what we do today, which is a birth dose of the vaccine, giving it within the first 24 hours of life, to moving it to 12 years of age. And I'm wondering if you could, there's nobody better in the country to talk about this than you. Wondering what's motivating that?
Yeah. So I fear that this is less of the issue of the president and more of the issue of the health secretary giving him incorrect information in his briefings. The president said in that press conference that the hepatitis B vaccine should be moved to 12 because he characterized the virus as a sexually transmitted virus. And it is true that hepatitis B can be sexually transmitted, but there is a very long history of transmission of hepatitis B from mother to child during childbirth and also during the early stages of life just from caregivers who may have hepatitis B. So we know historically that with the introduction of that vaccine to newborns, we really, in effect, shut down.
It's an extended echo.
Yeah, I thought we were not.
Okay. Is that better?
I'm so okay.
Okay.
Now it is.
Sorry. So in effect, we that birth dose of hepatitis B vaccine really nearly eliminated hepatitis B in the U.S. So we would have tens of thousands of cases every year of hepatitis B transmitted from mother to child, and last year it was about 24. And so there's someone is not telling him the right information about hepatitis B, and therefore I think he said something that was actually incorrect in terms of how the virus is transmitted and how important the vaccine is earlier in life.
Yeah, I was really surprised by that. I've been surprised by a lot, but I think the president, has adopted things that you've been a part of administrations on both sides of the political aisle. I'm happy to give the president, credit where credit's due on Operation Warp Speed and the COVID vaccine more broadly. And I was shocked to see of all the things, the hepatitis B to me felt the most egregious. And but I do. So we're going to come back, Demetre, on kind of newsy items in just a moment. I know many headlines we're showing this poll question right now. You just led. Up until recently, the National Center for Immunizations and Respiratory Diseases. And there is, I think, unfortunately, since the last 2 weeks have happened, with all this churn on COVID vaccine guideline changes, and as a result, people just wondering about flu and RSV as well. I am wondering if we can break through the noise for all the families out there that are listening now or will listen to this later. Can you walk us through what people should be doing for COVID, flu, RSV? And I think we have a figure that we'll track back to.
Great. No, for sure. And so I'll start with the easy one because there were not many changes made to this. But for influenza, for flu vaccine, the recommendation is that everyone over 6 months of age receive the flu vaccine. Also, it's important to note that if you give the flu vaccine in pregnancy, it confers some protection to the newborn.
Looks like we might. I know Dr. Daskalakis is just having some bandwidth. Oh yeah, no, I can see you back.
Okay. Can I just switch to my phone, Kelly? It's a lot easier. It's probably better.
Please go ahead.
Can you hear me now?
Demetre, if we shut the mic off on your main and the computer, would that help? Oh, I was just wondering maybe on your computer if that would help.
I think there's more of an issue. I think we're good now. So can you hear me?
Yep, perfectly.
Hello?
Loud and clear. We can hear you loud and clear.
Okay, great. I think if I'm on the phone, I think we're better off. Okay, sounds good. So for influenza vaccine, very straightforward. Under 6 months and older, important for everyone to get the vaccine. Last year, there were 281 deaths in children from influenza, and 90% of those kids were not vaccinated. And so it's really an important vaccine, especially for kids. I'll go to COVID next. So the recommendation that existed prior to the last meeting was really everyone who is older than 6 months of age should get a COVID vaccine. That changed a bit with an FDA approval. They added risk factors for individuals who are 6 months up to 64 years of age. And the ACIP took another step that added a barrier that's called shared clinical decision-making that requires some kind of of conversation with the clinician to decide whether or not to get the vaccine. It sounds good, but what it really means is that some places are requiring prescriptions for COVID-19 vaccine before there was no requirement for such a thing. So the current recommendation is that for COVID-19, 6-month-old to 65-year-olds, if you follow the FDA guidance, would require a risk factor, and over 65, age alone is enough to get the vaccine. So it's a bit confusing because the ACIP recommendations don't correlate to the FDA approval. So the bottom line is talk to your doctor about whether a COVID vaccine is appropriate. If you're over 65, it's a slam dunk. RSV, a bit more complicated. So the folks for whom it's very easy are folks over 75. That is a recommendation for a vaccine. Individuals who are 50 to 74, if they have risk factors, should also get the vaccine. The RSV vaccine also has a role in pregnancy. Now, interestingly, RSV, it doesn't cause a lot of problems in pregnant women. That's something that's really important. So when you're vaccinating at 32 to 36 weeks pregnant, it's not about protecting the mom. It's about creating antibodies that will pass to the baby at birth to protect the child for several months. If their mom does not get that vaccination in pregnancy, for newborns in their first RSV season, there is an alternative, which is a monoclonal antibody, which are antibodies from the outside that are administered that can also protect the child for several months during the RSV season. So just to review, COVID, ask your doctor. Flu, everyone over 6 months old should get it. And RSV, folks over 75 should absolutely get it. Pregnant women should get it in the 32nd to 36th week of gestation. And if they don't, their newborn should get nirsevimab or clesrovimab, which is a monoclonal antibody that prevents RSV in kids.
Demetre, can you explain, when we talk about shared clinical decision-making?
Yes.
It sounds like, oh, of course, have a conversation with your medical provider or engage in share. It sounds eminently reasonable that they're saying it, but what are they really doing by suggesting that? And I say this to the audience out there. My wife's a pediatrician. We're very close to some of the senior leadership at the American Academy of Pediatrics. And the sense I get from, say, frontline pediatricians is what they're doing here is just they're creating churn and confusion and anxiety, and this is actually going to be a barrier to care. But I'm curious how you think about that bit and how we should all be thinking about it.
Yeah, no, I agree with you. I think that the problem is the words shared clinical decision-making, they sound really good. But it actually is something that creates more administrative hurdle. So, I mean, really, all vaccine conversations like COVID-19, you're sharing that decision with whoever the vaccinator is. So you're having a discussion, you're having a conversation, you're getting materials to consider what's right for you. But the actual sort of decision by ACIP to make it shared clinical decision-making means that often states will require an additional step, which is some kind of proof that there's been a conversation with the clinician. So that means that, in Georgia, which is where I live, as an example, if a child or an adult wants to get a vaccine from a pharmacist, which is, again, where the majority of vaccination happens in the U.S., that child or adult will need a prescription from their clinician, which means more steps. And so, the truth is all vaccination is a shared clinical decision because you accept the vaccine or you don't. But that actual language creates some administrative barriers and even some complexity in terms of what insurances will cover. So they made it harder, not easier.
Could you speak a little bit about the concerns when it comes to needing a prescription? Where are we when it comes to that? And how does ACIP factor into the need for prescriptions or not for some of these vaccines?
Well, so they tried to pass a resolution about a prescription being necessary. And frankly, I think that's a reflection of the fact that the folks who are on the ACIP now are not necessarily very experienced in doing vaccine work. So when they agreed to shared clinical decision-making, that really creates a tapestry of barriers across the country. So different states interpret that in different ways. And so it means that in some states, you can go to the pharmacy and get it, no problem. And in other states, the pharmacists need a prescription. So by doing what they may have thought was increasing personal choice, they actually reduced personal choice and made informed consent even harder for patients. So I think part of it is, again, the committee chair described the committee members as rookies, and this may have been emblematic of the fact that they didn't understand sort of what the implication was for vaccine policy.
So is it the case, because here in Washington State, and some of our audience members, I know we have members across the country, AFT, and for those that will see this afterwards, 2 million people across the country. So I know different realities in different zip codes. Here, our state health officer issued a standing prescription. And for our audience members, that basically means we do not need to then hunt for a prescription to get a vaccine for COVID, specifically for the COVID-19 vaccine. Does that model exist elsewhere, Demetre, or is this very much based on where you live? You might actually need a prescription, or wondering how we have, or is it because ACIP did not require it? Does that mean that really nothing is different than last year?
Yeah, no, I think because of this designation of shared clinical decision-making, every state is different. And so I think depending on sort of what the state's strategy will be, some states like Washington create a standing order. Other places may not do that, or they may not be able to legally or from the regulatory perspective. So it becomes very complicated. So it is really like state by state, locality by locality, and honestly, sometimes if you're looking at pharmacies, pharmacy by pharmacy. So I think that it created more confusion than solved for any problem.
What would you recommend? So first line is medical provider. If somebody's having difficulty accessing, or there's a delay in communicating with their medical provider, is there an easy way to find out whether or not somebody could go to their local pharmacy and get a vaccine like they're used to? Or just wondering what kind of your thoughts on navigating at the local level, recognizing everybody's situation at the zip code level might look a little different. How do you figure out what you actually need before you go to the doctor's office?
Yeah, I mean, I think that especially if you're going to a pharmacy, it's know before you go. I think that the best advice, last year you could roll into the pharmacy, buy your toothpaste, get your flu shot and your COVID shot. It may not be that easy state by state. And I would say rather than trying to figure it out, which I think is hard to do online or looking at the state websites, don't even go online to the pharmacies. I think it's worth a call before you go in. I'll tell you that I had patients in Atlanta that went onto the pharmacy's web pages to schedule, and they got to a wall that said, you need a prescription. And so it ends up that when you called, in fact, you need a prescription in Georgia, and you also need to put a diagnosis code on it. That is one of the diagnosis codes that are on the list of underlying conditions. That's different state to state. And there's some places where the governors have actually, said that they're sort of keeping to the everyone can get a COVID vaccine strategy. And so it's the best plan is call your doctor before you go, or call your pharmacy before you go. Another thing that some folks do is they also access some of the pharmacy-associated clinics that are on site to be able to get one of those prescriptions. So that is another strategy. So places that have the sort of point of care clinics that are right by the pharmacies, they will sometimes direct you there to get your prescription so that the pharmacist can give the shot.
And Demetre, can I also get so your know before you go, and then in terms of what would you recommend, or so when it comes to for our audience here, just since we're going through the actual slides here, COVID-19 eligibility, you already went through that. MMRV, take us through the changes with MMRV. So now we're going to switch from respiratory viruses and COVID, flu, RSV to a different set of conditions here. MMRV, take us to what we have to worry about there, or what do we have to think about?
So it's pretty confusing. So there are measles, mumps, rubella, and chickenpox are vaccine-preventable diseases that vaccines have really revolutionized. Generally speaking, most kids get the measles, mumps, rubella combination shot. That's about 85% of kids last year who got that. A small percentage, 15%, get a different combination shot, which is the measles, mumps, rubella, chickenpox, or MMRV vaccine. When you look at the pediatric schedule for vaccines, the measles, mumps, rubella, chickenpox combination shot, or the MMRV, is generally not the first line that's recommended. The normal MMR is recommended with an additional shot, which is the chickenpox shot, mainly because there is a risk of seizures after a fever when you take the shot that has the four vaccine combination, the MMRV. So based on that, the schedule has always said that start with the MMR, and you can use the chickenpox shot separately unless there is a special circumstance where the patient's parents or the family and the pediatrician decide that there's a need to use a combination shot. And so very often that has to do with convenience, because the child may live far away from the doctor. It may be hard to come back for more shots. The child may be averse to getting an additional needle. So it was always an option, but a second best option because of the potential risk of a seizure after a fever related to the vaccine. So that's been there for really years now. But because there was some interest by the Secretary of Health to remove this vaccine from the schedule, the Advisory Committee on Immunization Practices, the ACIP, reviewed it. There was no new data. Nothing new was going on. And they recommended to remove the MMRV, that combination vaccine, from the schedule. And so what that means is that kids will have fewer choices and their parents will have fewer choices for what to do to vaccinate them. So it means that either a kid will need another visit or potentially another needle in a circumstance that there may have been a reason why pediatrician and parents would have decided to give the MMRV. So there was no real public health problem, and there's nothing that's really solved for, except that it did remove one vaccine out of the repertoire of vaccines that pediatricians could offer kids.
It's interesting. It's reflecting on what you just shared there, which is it's taking autonomy away from that doctor-patient-parent relationship and that conversation, quote unquote, almost seemingly the opposite of shared decision-making that they're saying for one vaccine. Now they're saying we're not even going to allow you to engage in a conversation with your provider on something that may make sense. So almost seemingly contradictory. Doesn't it seem like that to you?
I think that's right. I mean, I think that the discussion during the meeting was a lot about, how great pediatricians were and how aware they are of the risk, because, they only 15% of them gave the vaccine. But the flip side of that is that pediatricians are thoughtful. They know vaccines better than any other doctors know vaccines, and the 15% of administrations were likely due to a very good reason to give this vaccine that may have a different risk profile. So, in effect, there will be kids who, like I said, will either get another shot, another needle, or potentially would have to come back for another visit because the ACIP decided to remove the vaccine from the schedule.
Okay, great. We've talked about hepatitis B. We've now talked about MMRV. I should also just note that the president, since the president's picking up or probably being given some messages to share on social, he shared on social on Friday, Demetre, you may have seen, for parents to spread out shots over 4 to 5 visits, and was in that same sort of tweet, was referencing hepatitis B and then MMRV, and there's kind of a lot there. It was hard to parse out. But I mean, just to clarify, and Demetre, please improve on this, this is a 2-shot regimen, MMR. And so if you were to split it, MMR and varicella, like what you just said, for that first shot, you get MMR and varicella separately for a young infant between 12 and 15 months of age. And then you can get the combination shot for that second shot between 4 and 6 years of age. These are still just 2 shots. And he was recommending in his truth, I'm reticent to even repeat it, but to get measles separately, mumps separately, and rubella separately. Is that possible?
Well, this goes back, Vin, to my prior comment that when I heard that, my first reaction is like, he is not being briefed very well by anyone who's an expert. In the United States, the Food and Drug Administration does not approve separate measles, mumps, and rubella shots. So even what the recommendation was that the president made is impossible in the United States. And I'll say also that, to get us there isn't just an executive order. So in order to have a separate measles, mumps, and rubella shot, there would have to be studies that would be randomized and controlled. They would be large. They would be very complex. And it's unlikely that there's going to be manufacturers of vaccine that are going to be interested in splitting up measles, mumps, and rubella when the MMR combination has been so successful and so well tolerated. The thought also of spreading out the vaccines differently than they are currently recommended. There's a whole work group that has been put together at new ACIP that's supposed to be talking about the schedule. So when I heard that, it made me worried that Secretary Kennedy already had a plan for what that was going to look like, and that would be playing with a vaccine schedule that has saved well over 1 million lives, hundreds of millions of medical visits, and I think at the last count, trillions of dollars in societal costs. So, again, it seems as if there's another agenda that's driving what you heard from the president, but it's certainly not science.
Okay, Demetre, thank you. I know we want to spare a few minutes at the very end for Tylenol and a few other newsy things that are happening, but we just covered seasonal vaccine recommendations, COVID, flu, RSV. I did see a question in the chat, Demetre, that we want to make sure we tee up for you. There's no one better here. From one of our audience members, what are the risk factors that would get someone 50 plus to get RSV?
Yeah, it's a great question. And so they're listed on the CDC website, but generally it's underlying chronic diseases, lung disease, immunocompromisers, something that makes your immune system weaker. So I think really it mainly focuses on underlying lung disease. I'll tell you that the FDA has approved RSV vaccine all the way down to 18, but the ACIP has not discussed 18 to 49-year-olds yet because it hasn't made it on the agenda. Again, because they favored doing the hepatitis B and MMRV discussion that really didn't add a lot to our lives. But yeah, I think ultimately my advice is that list of underlying conditions on the CDC website is still great. And so it's good to take a look there to see if you have any of them. But generally, they focus on immunocompromised and lung disease. They're not that dissimilar from the risk factors identified for influenza. So I would take a look there, and it would give you a better list than I'm going to right now.
Excellent. Thanks, Demetre. And then, great. So I think we've covered COVID, flu, RSV. We've talked a little bit about the hepatitis B confusion. Birth dose is still really, really important because multi-modes of transmission beyond sexual transmission to include blood exposure, which is why we give that first dose of hepatitis B at birth, not wait till 12. And then you did help clarify the MMRV discussion. And I love how you said it. None of these things are really adding any material benefit to the lives of Americans. It's just a lot of confusion and talk. Kelly, I know, Demetre, it's just given the role that you were just in, I think it's really important for the audience, and this is a large, we're talking to 2 million plus people really at the end of the day, and plus the general public. I want the audience to get your response to what Secretary Kennedy put out on his Twitter handle yesterday. And we're mindful of what we show because we don't want to just blatantly show mistruths and spread confusion. But I think it's important to show the first half of the video. It's about a 7-minute video, so we'll show the first 3 minutes. And then Demetre, we'd like to come back to you on the other side to help give context and to explain away what the Secretary is putting out there. So if we could tee that up for Demetre and for the audience, please.
Hi, I'm Robert F. Kennedy Jr., your HHS Secretary. At my recent Finance Committee hearing, Senator Cantwell showed us this chart to illustrate the decline in infectious disease during the 20th century. The vaccine industry has long used this kind of chart as proof of the common claim that vaccines had saved hundreds of millions of American lives. The momentous 70% decline in mortalities in the United States and Western Europe from contagious diseases since 1900 marks one of the most monumental public health advances in all of human history. Was this really an achievement of mass vaccination programs, as many people, including Senator Cantwell, claim? The most comprehensive evidence-based study that rigorously examines this issue is a CDC-funded study that was published in 2000, performed by a team of researchers from CDC and Johns Hopkins University, and led by Dr. Bernard Geyer. The scientists meticulously examined 100 years of government infectious disease mortality data, and they concluded that nearly all the mortality reductions occurred before the introduction of vaccines, and that vaccinations could therefore claim little of the credit. For example, you can see from this graph that in 1900, some 13,000 Americans a year were dying of measles. By 1960, however, this number had dropped to a few hundred. But the measles vaccine was not introduced until 3 years later. Therefore, almost all the measles mortality had disappeared before the vaccine. So the measles vaccine can't really claim the credit for saving all those lives.
Great. Okay. Demetre, there's a lot there. For those joining us live and those joining us in syndication, it's a 7-minute video. We're stopping it at the first minute because I don't think there's any new themes he brings up later. But Demetre, you know, he's putting information out there suggesting that vaccines, in effect, had a minority role in controlling the spread of these diseases and their impact on human health. And, you know, I know you and I feel a certain way about it, but it's deceiving, it's misleading, but I think it confused people. So I'm wondering your thoughts.
Yeah, no, thanks for playing that, Vin. I think that one of the hard parts about misinformation is when it's partially based in truth. And so I'll start by saying, you know, I think Secretary Kennedy goes on to say that you know, much of the improvement that you saw in infectious diseases and in measles was driven by hygiene. He actually talked about chlorinated water, none of which actually will do anything for measles. So really what happened with measles, I think, was twofold. So I think first you have a sort of different living situation and environment. So that's true. And then also medical care became a lot better. People don't necessarily die of measles when they die. They die of other underlying conditions. And as supportive care got better from them and then antibiotics came onto the scene, what you saw was that all of the things that he said were true, that measles deaths actually did decline before vaccine because of what public health did outside of vaccine. Now, he stopped and didn't tell you the rest of the story, which is that the year before vaccine was introduced in the United States, we had the highest number of measles infections ever reported. So what that means is that antibiotics, good medical care, hygiene, better living conditions, it did improve mortality, but it didn't improve infection. When you introduce vaccine, what happens is that the vaccine shut down transmission. The year that Kennedy was saying excitedly that there were only a few hundred deaths, there were 500 deaths the year that he was referring to. After vaccination, when you make measles a rare event, measles deaths become a very rare event. And so it is a multifactorial thing. Lots of things contributed to getting us to the place in 2000 where we were able to say that we'd eliminated measles transmission in the United States. So by only giving you the half-truth, what you hear is that deaths got better before vaccine. But what you didn't hear is that deaths were nearly eliminated with vaccine. And in the United States, we shouldn't be tolerating 500 deaths from a vaccine-preventable disease. The goal is 0. And with a safe and effective vaccine with measles, when you add that to all of the amazing achievements of public health like hygiene and antibiotics, what you get is a country that eliminated measles. But we're seeing this year with over 1,400 cases, or actually 1,500 cases already reported, that we are now in the highest year of measles since we eliminated it in 2000. And it really is, again, an important call for vaccine, because rare measles means rare deaths. We've had 3 deaths in this country so far this year. These were the first 3 deaths that we've had in 10 years. So the sort of narrative that you're hearing from Kennedy, making you less confident in the role of vaccine, doesn't really help us get to the goal of 0 vaccine preventable diseases causing death and disability in children.
Demetre, can I ask you a follow-up question, which is, talk to me about, you mentioned measles. What about smallpox? I noticed you didn't talk about things like smallpox and polio. You really cherry-picked a few diseases. And I mean, to your point, there's a lot of reasons why health is better today than it was, despite, narratives to the contrary. But in some cases, it's all about vaccines, right? In some cases, you're right. It's vaccines are part of the solution. We all admit that. And they avert 500 deaths a year in the case of measles. But speak to us about...
polio is a great example. I think you're right. Polio is a great example, and we'll go to smallpox next. But polio is, hygiene is definitely a piece of what controlled polio. But ultimately, the way that it was eradicated from the U.S. was because of vaccine. And then thinking again of smallpox, smallpox is probably like the greatest vaccine success story in the world, where that has been eliminated off the face of the earth because of vaccine. And so, I think that it is very simplistic to say that all of infectious diseases have been made better by hygiene and living conditions. They participated in controlling those infectious diseases, but the ones that we've been able to eliminate or eradicate have had an effective vaccine that have been able to prevent transmission. So at the end of the day, that is misleading information, which is frankly straight out of a playbook for anti-vaccine rhetoric.
And just to put a bow on it, COVID-19 emerged in the modern age with vaccines versus without vaccines. I've seen any number of statistics on how many lives were saved, but even in the advanced society that we live in with sanitation, all the things that Kennedy is citing are what's improved health over the last prior century. None of that necessarily would have prevented 1 million to 2 million lives lost in this most recent pandemic. Can you speak to that? I mean, just the most recent sort of visceral example of vaccines saving lives, and him not touching on it whatsoever, and all the contradictions that lie kind of with their whole messaging on the COVID-19 vaccine. It wasn't all about sanitation, was it?
Yeah, then I think that COVID is a great example. We know that certain living conditions made COVID transmission worse, right? We learned that. It was sort of one of the lessons that we saw from the perspective of equity, in terms of who was overrepresented in the outbreak. But at the end of the day, contrary to what he's actually said, vaccine was really important in controlling COVID-19 into a more manageable disease. So even when it was not perfect in preventing transmission, it really took that virus from wild to mild, as we used to say at CDC, from a really severe infection to one that was manageable. If we did not have vaccine, I don't think that we would have been out of the pandemic as quickly. And I think that Secretary Kennedy has publicly said on several occasions that he doubts the role of vaccine even in that pandemic. So I think we all have eyes and ears many of us lived through the pandemic, unless we're very, very young. And I think we all remember how important vaccine was to getting us back to a normal life. And so, I think that propaganda means saying things without necessarily having a basis. And I think that, we need to remember sort of our own experience as well as the data that I think we'll all agree that the COVID vaccine was really important in getting us to a different point in the pandemic. No amount of sanitation or antibiotic would have been able to do that.
For those that are going to watch, thank you, Demetre. And I think we're going to pivot here for our last few minutes. And if you have questions, by the way, I know we had a few come in, by all means, please do drop them in the Q&A chat. I should note, for those, since this will get views, it's gotten a lot of views. 1.1 million views, Kennedy's post on his ex-HHS handle, or on the HHS handle. He posted his video yesterday. He ended the video in a way that, God, I'll just speak for myself here, but I know I'm channeling a lot of medical societies and our peers, Demetre, somehow saying that the public health establishment and folks like ourselves over-rely on vaccines, and we don't rely enough on therapeutics, on healthy lifestyle, exercise, counseling, a balanced diet. And that, the blatant mistruth and outright falsehood of that somehow we're out there only prescribing and talking about vaccines as a way to prevent illness and not talking about all the many other things that one can do to prevent illness, as though it's one or the other and it's a zero-sum game. To me, it bothered me that he framed it up there, because it was yet another example of him not seeking to partner with the very people that he should be accountable to, which are healthcare providers, whether they're nurses, doctors, pharmacists, creating sort of it's them versus us mentality. It's really bothered me. But for those that go and it's not the first time he's done it, won't be the last. I know you've seen it. But for those that view it, because he ends the video on that trope, I thought, again, deeply misleading, but deeply frustrating as well, because it's yet another injury in that relationship that he should really value, his relationship with all of us. Anyhow, Fed, Fed, if you're there, kicking it back to you to talk about, last thoughts from Demetre on some other items that have come to the fore.
Thank you. Thank you so much. Listen, this has been very enlightening. I do have a few questions that came up in the Q&A, and I'm going to try to really speed channel these to both of you, Vin and Demetre. Just in light of a potential federal shutdown, what is the impact on healthcare, both in terms of public health services and families' access to care? And I'll kick that to both of you, Vin.
Well, I guess in the interest of time, Demetre, yeah, please, go ahead.
Yeah, I could start. So, we're in a very interesting place in terms of how a sort of orderly shutdown usually occurs versus what's happening now. And I think, usually the OMB, which is responsible for making sure that there's an orderly shutdown, usually releases information about what services will be available and what will not. And they didn't do that this time, which I think creates some complexity. My understanding is that folks have had to go agency by agency to sort of see what happens. It sounds as if many of the sort of Social Security services are going to remain open. It sounds like the VA essential services will remain open, but there's not one place where you can look right now to identify that because of unclear communication that's coming from that office. So, I think it's hard to predict what is going to happen sort of jurisdiction to jurisdiction, but definitely a partial shutdown may impact some of the less essential services that are a part of what jurisdictions do, especially if it requires federal funding.
Got it. Thank you so much. And I have one final question for you all. And this is really, I want to talk to you because I'm a Floridian. In some states like Florida, obviously, like we've stated, are rolling back longstanding vaccine requirements. From your perspective, what are the potential long-term consequences for schools and communities, families? Florida is a is a place where a high percentage of the folks are over the age of 60. What's the long-term impacts of these rollbacks and vaccine requirements?
Vin, do you want me to start, or do you want to go?
Yeah, let's go to you to fit in, and then we have one more question on Tylenol before we wrap.
Okay, great. So again, though I can't speak to the motivation, I can tell you what the outcome is of rolling back vaccine requirements for school. And it's going to be that, it will be easier for folks to avoid vaccine than to get them, which will mean that we will have vaccine preventable diseases that will be more likely to infect people who are unvaccinated. And I think you raise a really important point, Fed, which is that it's not just about the health of the individual or the health of the school, but also the health of the people around you who either cannot get vaccinated or don't respond as well to a vaccine. So we're going to see that community immunity against many viruses is going to go down, and bacteria will go down. And the effect will be that we'll have more measles outbreaks, that we're going to be susceptible to polio if polio is pulled back, and that folks who aren't able to get vaccinated because of a weakened immune system or other reason will then be at increased risk for those infections as well. So again, I can't speak for the motivation, but I know what the outcome is. When we have decreased vaccination coverage, we have more vaccine preventable diseases, and that means more illness, more time off work, more people not going to school, but then also death and disability, which is the thing that we've been able to avoid for decades now.
Absolutely.
Thanks, Demetre. And I know we're at the top of the hour, but just to wrap on Tylenol, Demetre, as a public health expert, just wondering how you're counseling people coming to you or asking for your advice, or just generally worried. Is there something new here that people should be worried about if they're, say, a pregnant mom needing to take Tylenol for an indicated reason, or use of Tylenol in a young kid? Sort of a different frame to the question, but have we learned something new in the last few months that didn't previously exist that should cause us to worry?
Yeah, I think that this is very similar to what I talked about with the measles, mumps, rubella, varicella vaccine and the hepatitis B vaccine, where there's nothing new. Nothing really new has happened. There have been there have been studies historically that have shown that Tylenol may have an association with some neurocognitive changes like autism or ADHD, but there's never been any causal relationship drawn. So in other words, like it's in the same zip code, but doesn't mean it's the same city, right? Like it's not linked in that way. So I think what we're seeing is that the secretary had committed to a quote answer on autism by mid-September, and this is the only thing that shook out. And there's nothing new about it. And it goes back, I think, to the same conversation that we were having earlier, that my advice to people who are pregnant is talk to your OBGYN. For decades, they have said to use Tylenol judiciously. It is the only drug that can be used for pain and fever reduction in a pregnant woman. And the risk of fever and pain in that woman can also be high and could threaten both the woman's well-being as well as the pregnancies. The ACOG, which is the American College of Obstetrics and Gynecology, as well as many other medical associations, have released statements really calling the announcement at best dubious. And so it really is about using drugs judiciously during pregnancy. And my answer always is talk to your OBGYN, because they know better than Secretary Kennedy, who, remember, gave you advice earlier that you shouldn't be taking advice from him because he's not a medical expert. And so I think that it's probably fair to redirect that question to medical experts like the folks who help women during pregnancy.
Excellent. Thank you, Demetre. Fed, I'm going to kick it back to you just to close this up.
Thank you. Thank you, Dr. Gupta, and thank you, Dr. Daskalakis. I appreciate you all being here, your wisdom, your perspectives tonight. You've helped us to hear the melody through the noise. As a former music teacher, we all need to be singing the same tune as it relates to our health, because one impacts another, not only one person to person, one community to community, one state to state. And so thank you all for speaking truth. here's what I'm taking away. Science and truth matters. And when educators and families and communities have the facts, we can push back on misinformation and keep our kids healthy and safe. That's what this union is all about. All 1.8 million of us, and by extension, millions more of our families, making sure our members and our schools and our communities have the support they need to thrive. Thank you for joining us, and thank you for your great questions, both on vaccines and in the final 10 minutes we set aside for other health concerns. Every one of these conversations makes a difference, especially in the world we live in today. Let's stay safe, let's stay healthy, and we'll see you at the next Vital Lessons. Thank you, Dr. Gupta. Thank you, Dr. Daskalakis. Good night.
Thanks, everybody.